Hi, everyone, and welcome to this webinar about the new white paper, Safe Air Now. We're just going to wait a couple of moments to allow our attendees to join the call. So if you just bear with us for a couple of minutes, we'll kick off in just a moment. Well, all right. So thank you everyone for joining. As I said, this is a webinar to present a new white paper which has been produced by Ending Workplace TB alongside the Stop TB Partnership's Ending TB Transmission Initiative and the Private Sector Providers Constituency to the Stop TB Partnership Board. My name's Yannicka, and I have the pleasure of supporting the development of the white paper. And we're also really excited to be hosting this particular webinar together with the team at TBProof, which is an amazing advocacy organization that grew out of work focused on occupational TB among healthcare workers, as well as Ending Workplace TB members, Apollo Hospitals, who have really been leading the charge through their own work and their CSR portfolio. So a huge thanks to all those partners for their support. It's great to have you all here. I know there's another webinar on diagnostic systems that's just wrapping up, so I expect that we'll have a few more colleagues joining us. But I think we'll get started with housekeeping and introductions in the meantime. Just a quick heads up that the session is being recorded, and we'll share that via the Ending Workplace TB website in the coming days. But we also should have some time at the end of the session today for some questions. So please do make sure make use of the Q&A and chat functions to interact with our speakers. That should be at the bottom of your Zoom screen. For those of you who don't know, Ending Workplace TB was founded to support and accelerate the action taken by employers specifically to tackle TB amongst their workforces and the communities that they work in. Some Ending Workplace TB members employ healthcare workers themselves, but I think all of them rely on healthcare workers in some way because they keep their staff and their families healthy and able to work. I think the COVID-19 pandemic threw both the importance of healthcare workers and the risk that they face as a result of their work into stark relief. And for the first time, people were really thinking about infection prevention and control in terms of airborne transmission rather than just hand washing and sanitation. And I think we also saw the dangers faced by patients who go into healthcare facilities for treatment and end up exposed to another pathogen because of the poor IPC in those settings. And I think with lots of resources on IPC being really technical and oriented towards implementers and the real lack of focus on airborne IPC specifically, we wanted to explore that issue from a policy lens. What does the landscape look like? Where are there opportunities to drive forward the conversation and really make a difference? Before we delve into that conversation, we also really wanted to make sure you hear from someone with personal experience of what it means to contract TB while you're working in the health sector. And so we're really delighted to welcome Wubshet to the call to offer some opening remarks for us. Wubshet developed TB while he was a medical student in Ethiopia and can really speak to how challenging that experience can be. After we've heard from Wubshet, I'll walk you through the white paper before I hand over the mic to our excellent panel. We'll have a longer conversation about the paper's key recommendations and what different actors can do to move that needle. But I will stop there and hand over the mic to Wubshet. Wubshet, please turn your video on and tell us a little bit about your experience of occupational TB.
Thank you, Janik. So you all can hear me, right?
Yeah, we can hear you. Thanks so much.
Thank you for having me. So I'm here to share my personal experience regarding tuberculosis. So I acquired tuberculosis while I was a final year medical student in my university. It's one of the popular universities here in Ethiopia. It's a medical college. So during our time while we were working in the hospitals. So having this IPC things like masks, sanitizers, or let alone respirators, or everything somewhat was luxury. So we were practicing without those personal protective equipments. So I acquired tuberculosis while working in the hospitals. It was kind of difficult time. I was diagnosed early since I was working in hospital. So TB is rampant here. So I was diagnosed early and started treatment immediately. But the difficult thing appeared when I failed to improve despite the first line and the second line treatments. So working up for or considering multi-drug resistant tuberculosis was it was considered early, but getting the tests, getting the treatment was difficult. So it took me taking treatment for the first line and the second line, around 2 years of treatments to be diagnosed for multi-drug resistant tuberculosis. Then after 2 years, I was diagnosed and I was started on the proper treatment. So basically it took my lungs to get the proper diagnosis. So I had this amazing support from the families, colleagues, friends, and everything. But the role reversal was somewhat very difficult for me. So I think it's somewhat everywhere, but it's thought that when you are a medical professional, getting sick is somewhat a bit far for you. But when you become sick and see or be on your patient side, it's kind of difficult. And since there was no proper IPC requirements in other hospitals too, there was stigmas I faced from even some of health professionals. I don't blame them. It was just because of they don't have the proper personal protective equipment. So they were afraid of acquiring multi-resistant tuberculosis and everything, even after I was non-infectious. And after that, I was treated and I got cured after 2 years of treatment. And it was everything was quite well, but the issue reappeared when COVID pandemic hits. And during that time, since I had this fibrosis in my lungs and everything, it was quite difficult for me. But I didn't stop working, so I was working the whole time. Everybody was supportive and everything, and the vaccines came and everything went back to normal again. So the final thoughts. Currently, I'm working as part of TBProof and advocating for more shorter regimens and also proper infection preventive equipments in the hospitals and everything. But I still suggest that if we give a fraction of attention to TB as we gave to COVID-19, I think we could possibly change everything. So I'm so excited to see what the white paper goes and everything, but this is my experience with tuberculosis. So if anyone wants to ask questions or need more explanations, I'm happy to do it. Thank you.
Thanks so much, Wubsha. I know that retelling that story isn't necessarily the most entertaining way to spend a Wednesday afternoon, but I really hope that that kind of testimonial explanation has really driven home the importance of taking action on airborne IPC and tackling stigma and TB in general. To the audience, I should also flag that Wubsha provided a short case study in the report, so if you'd like to refer back to it, please do have a look at the white paper. On which note, I will walk us through the rest of the white paper itself, just to provide a brief sense of what it is that we are talking about today. I hope you can all see that screen. Shout if you can't, but I will dive straight in. So we've seen statistics that highlight the higher risk faced by healthcare workers pretty consistently over the past few decades. 1.8 billion people use healthcare facilities that lack basic water facilities, which I think is really the context in which airborne IPC in particular has slipped from the agenda. But I think it's important to recognize that, as we said, airborne transmission does happen and it does put healthcare workers and patients at significant risk today. TB infection, or what used to be known as latent TB infection rates, are reported to be around 25 times higher than the general population among healthcare workers. Healthcare workers were also 5 times more likely to be hospitalized with MDR-TB compared to the general population in a study that was done in South Africa. We can look at other pathogens too. So during the 2014 Ebola outbreak in West Africa, healthcare workers were a staggering 21 to 32 times more likely to contract the virus. And as I said, COVID-19 also really highlighted how bad Airborne IPC can really add fuel to the fire of an outbreak. And finally, I think just thinking about kind of health more holistically, healthcare workers are also among the professions who are at highest risk of occupational burnout. And so while the moral and legal principles of a healthy work environment is obviously crucial, I think it's also important to underline that poor occupational health has consistently been shown to reduce the quality of care and lead to worse patient outcomes. So getting on top of this is really something that we need to do from the perspective of employee rights, but also services, health service sustainability and the broader SDG agenda, including public health targets. I think it's also worth just saying from the outset that while the focus is often on doctors and nurses when we talk about healthcare workers, we need to take a much broader lens here. There's a whole range of professions: cleaning staff, catering staff, receptionists, porters, medical students, community outreach workers, subcontractors, and so on, who are all exposed to pathogens when working in healthcare facilities, and sometimes even have a higher risk of exposure and patient contact than clinical staff. And a message that will come through the white paper again and again is that something is always better than nothing, but at the same time, there's no point in protecting your senior clinician when the catering staff that comes into contact with every single patient over the multiple times a day is being ignored. The white paper itself consolidates data from international reports and academic literature, but also is informed by kind of input from expert witnesses whose time and expertise we are immensely grateful for. The general message is that the current state of IPC globally is profoundly inadequate. While there's significant variation, particularly when considering high income settings and larger private sector providers for whom IPC is really a reputational imperative, across lower resource public and private providers, the status quo really reflects both the lack of financing that's available in those spaces and the neglect of this agenda in particular. The most recent WHO report that presented data up to 2022 found that only 50% of countries had an active IPC program at the national level, and not a single facility that was assessed in the low-income country met all the minimum requirements defined by WHO. Often countries will have robust policies and frameworks, but there just isn't the resourcing, training, staff leadership, monitoring or enforcement to ensure those are consistently implemented, in addition to just the infrastructural barriers that Wibshed mentioned around lacking access to core IPC equipment. And specifically, again, in settings where hand washing is kind of seen as a challenge, airborne IPC is often classified as just being too hard to do. The other discrepancy we found between high-end private providers and other sectors is that in private sector facilities, which generally see fewer TB patients and don't necessarily have TB-specific units, the approach to IPC is much more integrated across the whole facility, whereas in contexts where airborne IPC, whereas in other contexts, airborne IPC is really seen as only being relevant once you have a room full of people being treated for active TB disease, which is obviously a challenge when you think about transmission hotspots outside of those treatment rooms. We see that pattern repeated in relation to more detailed guidance offered by WHO around administrative, environmental, and transmission-based controls. Administrative controls such as proper triage and waiting room management is really restricted by staff capacity and false perceptions of risk outside of treatment rooms, as I mentioned. Environmental controls such as ensuring proper ventilation can be achieved relatively cheaply with proper construction that prioritizes airflow, but that obviously needs to be considered when you're constructing. And so it's rarely the standard. And in some countries, things are actually moving backwards as facilities are moving to closing windows and installing basic air conditioned facilities. There are some higher tech interventions such as upper room ultraviolet germicidal irradiation and CO2 monitors, that those have become much more affordable also as a result of the pandemic, but they still require an investment and an acknowledgement from service leaders that those tools actually need to be deployed. And finally, on transmission-based control, such as proper PPE wearing, it's again something that's very variable. We heard that in facilities where monitoring and enforcement introduced during COVID has really been sustained, the culture has really fundamentally shifted. But in many contexts, the standards have slipped back to the old ways with lots of performative PPE wearing when an inspector is in town, but otherwise being perceived as a barrier to clinical care rather than a critical component of that clinical care. The white paper also looks at occupational health. And as those kind of occupational health services are really crucial to ensuring that occupationally acquired TB can be detected and managed effectively. Regular screening is again fairly well established in larger private sector providers and public services in high-income countries, while lower resource settings do generally have occupational health services in place, but they're much more reactive, relying on healthcare workers to identify their symptoms and actively seek care. Given the significant levels of stigma still attached to the disease, including among health workers themselves, that process is often delayed, putting them, their colleagues and patients at risk. Another finding worth highlighting is that mental health and well-being are only very rarely included in occupational health services at the moment, which is obviously a massive gap. And also that TB preventative treatment is rarely offered to healthcare workers in high burden contexts, despite recent guidance in favor of doing that, particularly using those shorter regimens that are now available. The white paper closes with some basic recommendations for practitioners, healthcare leaders, policymakers, and advocates. I think it's clear that there isn't a golden bullet. It's really about taking integrated action and figuring out effective and feasible solutions, be that in an individual healthcare facility or thinking at a higher policy level. We really need to change how we talk about IPC in general and airborne IPC specifically, from a nice to have to being really essential for quality of care, disease prevention, and kind of pandemic prevention and resilience. To advance the agenda, airborne IPC needs to feature as a priority in kind of priority policy frameworks and reporting schemes, thinking about the frameworks that are being put in place around AMR, around the implementation of the UN high-level meeting on TB political commitments, same for UHC around pandemic strengthening. National and local IPC and occupational health programs require urgent investment with earmarked budgets and mechanisms which champion sustainable leadership. That is really a critical finding from the white paper. Similarly, national policy frameworks need to be bolstered, ensuring standards and enabling partnership across the whole health system, including drawing on some of the lessons learned from the private sector in many countries, which, in some cases has really been leading the way. We can't let the enemy we can't let the perfect be the enemy of the good. That's the way around. There's scope for really significant innovation if we allow locally responsive solutions to be trialed and refined by empowered healthcare leaders. And finally, we really need to invest in stigma reduction initiatives that reach both patients and healthcare workers, as regardless of how good your IPC systems are, stigma can really undermine them and undermine the standard and quality of care that people receive once they have been diagnosed with TB. And thinking specifically around what the TB community add, I think it's worth saying that despite the weaknesses identified in IPC standards around the world, TB services are often really ahead of the curve, which is in no small part why so many TB wards were repurposed during COVID-19 and often quite effectively from the perspective of preventing nosocomial transmission. Crucially, I think as we move away from inpatient care to more community care models in TB, it's critical that the IPC standards that we've had in place in inpatient units are transferred to those other healthcare settings, which will not only benefit the TB response, but public health as a whole. And finally, I think the TB community knows how to talk about IPC as a welfare and rights issue, and do so in a way that isn't continuing those that stigmatization that is really undermining the TB response, which is so crucial. I'll wrap up there because I know that our amazing panelists will have lots of very interesting things to say about this issue. But I'll just close by reiterating our thanks to the expert advisors, the witnesses, and partners that made this resource possible and shared some amazing case studies that are presented throughout the white paper. I'd really just encourage you all to have a look through the white paper. It's not overly dense. You can read it with a cup of tea. And please do consider using it in your policy and organizational advocacy. With the recent UN high-level meeting on AMR and a new WHO IPC action plan and monitoring framework that was launched at WHA this year, I think there's real scope to make a difference here. But I will stop there and hand over to Professor Ruvandi Nathavatharana, who is very kindly going to be facilitating the panel discussion. I will stop sharing my screen and over to you, Ruvandi.
Thanks so much, Yanniga. I'm really looking forward to this discussion. I've thought a lot about TB infection prevention and control as a researcher for thinking about occupational health screening and strategies like the first infection prevention strategy in the facility, in health facilities, as well as from the advocacy standpoint through work with TBProof. So I'm really just delighted I'm going to welcome our panel. I'm going to do brief introductions so we have lots of time for discussions. Today we have joining us Dr. Paul Jensen, who is worked with CDC previously and is now an independent consultant in Airborne IPC and helps to lead the Stop TB Partnership Ending TB Transmission Initiative, the ETTI, and who's an engineer by profession. And the next panelist is Dr. Alina Burhan, who is a clinical senior lecturer in the Department of Pulmonology and Respiratory Medicine at the Faculty of Medicine, Universitas Indonesia. She's also a member of the Private Providers Delegation to the Stop TB Partnership Board, and I think we'll bring some key insights through that work as well. Dr. Sunitha Naredi is an infectious diseases consultant who currently works at the Apollo Health City in Hyderabad, who has particular areas of specialism, which include nosocomial infections and drug-resistant TB, and she's a fellow of the IDSA. And then Erica Mulholland is an epidemiologist for the city of Cape Town and supports the primary healthcare program. She has many years of experience within the South African, supporting the South African TB program, and chairs several epidemiologic and clinical forums that are dedicated to improving the national TB response. And she's also a very active member of TBProof, a South African NGO focused on TB advocacy. And we'll talk about some of the work that she led related to occupational health and TB IPC in the South African context. So loads of experience on and insights from the panel. I'm going to open up with a question for everyone. Would love to know your thoughts about what do you think are the sort of biggest barriers to strengthening airborne IPC in healthcare settings, and perhaps also what enablers do you see? Perhaps we can start with why don't you go first, Sunitha?
So thank you for the question, Ruvandi. So when you talk about the major challenges in terms of strengthening the airborne infection prevention control in healthcare settings, there are several things that you have to be concerned about. A lot of places, like for example, our hospital is built 30 years ago when we did not know enough about IPC or airborne IPC. So changing the infrastructure once it is built is much more difficult when you're planning ahead of time and building infrastructure with proper planning. And that's one of the major constraints I see in a lot of the places, changing infrastructure that's already built. Then you'll have resource constraints as well. Finances that have to be spent, not just for the infrastructure, but also for things like PPE, diagnostic tools, sometimes HEPA filters. All of this are cost money. If you looked at the previous infrastructure, say about 40 to 50 years ago, we were using IPC in a different method. You had TB sanatoriums where you had huge rooms with high-rise roof, large windows, which has good cross ventilation. The cost of infrastructure there was much lower, and you had very good air exchange in spite of no extra effort put in. You just had to open the windows. Whereas now you have all these facilities which are air conditioned, you have fixed windows, there's no air movement, and that becomes a problem. And you have issues with training and awareness. More and more people need to be trained. Even if you train, the protocols are not always followed. There are cultural factors where you've been hearing about TB all your life. What is the big deal about it? And on top of this, when you have a high patient volume, you have too many patients moving in and out, constantly have so many patients to take care of, trying to follow the protocols, which will add more time, it becomes difficult. Just the burden of patient population and the disease population. And sometimes probably increasing community engagement can help, which is lacking a lot of times. We don't involve people who have gone through the problem in our patient decision making. So some of these things can be improved on to help with the IPCs.
Thank you. Erica, why don't you go next?
Hi, thanks so much. So I'm not going to mention the things that have already been discussed, but I think further challenges are associated with sufficient training on TB IPC. So, this really then feeds into the risk that maybe health workers or patients have around their perceived risk, and then the mitigation efforts that they take to protect themselves against TB. And if people obviously then aren't, understanding of how they could be impacted, the measures to mitigate that risk are less prioritized by those individuals. And I think, generally, I'm specifically within the South African context, as well as local implementations to support IPC implementation. So, for example, I worked on a project to develop implementation guidelines focusing on IPC and occupational health for health workers exposed to TB specifically. However, despite the development of an implementation guideline, it still hasn't been endorsed by the Department of Health or rolled out. And there's still a lack of a clear, consistent policy, despite that having been drafted many years ago. And so without these kind of governing documents, it becomes very hard to have any sort of framework that anybody references when it comes to implementation of IPC. So people are reliant on outdated guidelines or ineffective methodology. I think another factor that plays into this is, some of the stigma associated with implementation of IPC in facilities. So, for example, mask wearing in facilities. Sometimes patients perceive that as being stigmatizing. And I think it comes down to balancing health workers' responsibility to balance, obviously not perpetuating further stigma, but then also having the ethical responsibility to ensure that risk is mitigated and people are protected within facilities, including themselves. And unfortunately, there was a big focus on implementation or mask wearing during COVID. And it's kind of like that just went out the window after COVID became less of a concern. People went back to their routine practices, or even seemed to push further away from wearing masks. So, currently, if you go into a lot of the health facilities in Cape Town, for example, where we know there's a high burden of TB, you'll find very few people wearing masks. And so that's obviously quite concerning. And I think, another challenge is, there's also not great monitoring and evaluation of occupational TB exposure, especially within South Africa. So we're not reporting on the development of occupational TB in health workers. We don't have any national indicators that look at any measures associated with IPC or occupational the development of TB disease in healthcare workers. And therefore, it really becomes hard to quantify what the issue is, and then further leverage resources. So there is a paucity of resources. We have challenges in terms of maybe upgrading infrastructure and facilities because we have limited resources, but without an actual contextual understanding of the burden of the problem. Of course, there is published literature, but I think having that evidence tangibly available to leverage further change, but then also having a framework in which we have indicators where we're reporting on our indicators and looking towards and making improvements, in terms of implementation of IPC or reducing the development of TB in health workers. It's hard to do so without a monitoring and evaluation framework. So those are some of the challenges. I think, mitigation efforts, there's some things that we are doing around administrative controls that can be done a lot better. I do think COVID-19 posed opportunities to think differently about how we triage patients and how we ensure individuals are getting access to chronic medications. So, looking at methods where people can do community collection of medication and, mitigate the number of people that we have coming to our healthcare facilities can be easy methods to implement. And there are already things that are being done for some programs and could be expanded further for other healthcare programs to, reduce the risk or reduce the burden of the number of people we have coming into our healthcare facilities. So that's just, a couple of things from my side.
Thank you. Paul, would you like to go next?
Yes, please. Thank you. And thank you for this group for putting this document together, because I really found it enjoyable to read. And I think one thing that could be perhaps slightly refocused, because I think it's a limitation, is if we take a look at WHO itself, and I know we can't change WHO, but we can perhaps push some people, is the global TB program, the bio-risk program, the pandemic response programs generally act independent. And for us to truly have impact, in healthcare facilities and beyond healthcare facilities, we need, all of these groups to play in the same sandbox, because the goal is the same. But we can't go into a facility and say, okay, you have to have these things for TB. And then the infection control people say, you have to have these things for everything except TB, which includes some airborne stuff. So anyway, that's the first point. The second point is a pet peeve of mine, and I'll apologize in advance, but that's misusing the term mask. Because when we're talking about masks, in general, we should be talking about surgical or procedure masks, which have a purpose in all airborne infection prevention control. And then we're talking about N95 or FFP2 respirators, which have a different function. And part of the education process should be explaining to people why you would use one over the other. And as an example from COVID, one of the most, I think, impactful posters that I saw was very simple. And it essentially showed somebody with a respirator, with a mask, surgical mask. And it said, I wear my mask to protect you, and I want you to wear your mask to protect me. And that's the kind of general messaging we need. Over.
Thank you. Thank you. Really excellent points. And Alina, would you like to go next?
Yeah. Thank you. So being the last, it will be less point. But anyway, I just want to say that TB program nowadays just focusing in diagnosis and treatment. Yes, recently we are talking about prevention, but however, those prevention meaning is PPT and vaccine, but we don't really talk about IPC. So I think we are making continuously that this IPC is being left behind. So IPC is not being prioritized. So I mean the barrier is that in TB program, prevention as such as IPT is not the main factor to evaluate the performance. You will get the good remark if you have like a high notification, high treatment success rate, but there is no evaluation on infection preventive control. That is a really a big barrier. Yes, if we then having IPC as a prioritized, then there will be a addressing of resources, training, implementation activities, monitoring, etc. So I think from now on we have to speak about the prevention meaning by IPC, not only TPT or vaccine. That's all. Thank you.
Thanks so much. I realize the hour is running by, so I want to try and focus a couple of loads of excellent points. Focus a couple of questions, and maybe with some directed questions. I wanted to think a little bit about how we can, as a TB community, sort of advocate for improved IPC and not limited to airborne IPC. And I wonder if Sunitha and Alina, maybe you could share some perspectives about public versus private health facilities. And then for Paul, I wonder if you could talk a little bit about how we kind of think beyond TB alone, and talk a little bit more about how we break down some of these silos and sort of leverage what we've learned from the COVID pandemic, as well as the many years of experience from TB beforehand. And Eric, I wonder if you could talk a little bit about the community engagement aspect that I think several people mentioned. So maybe I'll start with Sunitha.
Thank you. So when we talk about challenges in the public sector and private sector, I don't think they're too different, but some areas that are a challenge, like I can tell you. For example, in a private sector, in a corporate hospital or any private hospital, there is no department usually. Everybody is all together. Like there may be a general physician and an orthopedician and a psychiatrist all in the same area. So if you're trying to provide infection control for a particular disease, it doesn't work. Like Paul was mentioning, you don't talk about IPC for TB. You have to talk about everything in the holistic context. We talk about, okay, when somebody is coming into the hospital, you need to wear a surgical mask typically. We don't talk about an N95 mask when somebody is coming into the hospital, but we don't know whether they're coming in for a cough from an upper respiratory illness or from tuberculosis, where a surgical mask will not be sufficient. So it is a big challenge in terms of how to try to do infection control in the outpatient. A little bit easier in the inpatient sector, where you're kind of, okay, you know what disease the person who you're treating has, because you already triage them and then you put them into the respective cohort. But a huge challenge in the outpatient sector, and you cannot really differentiate one person from the other. They're all sitting in the waiting room together, and it becomes a huge challenge. We are still struggling with this. I don't think we have a clear-cut solution for this. Much easier in the inpatient, but outpatient, we are really having challenges. One way we do it is, at least in the places where we see more of pulmonary TB, we use air filters, particularly in the places where we evaluate patients, like in the doctor's evaluation room, which is at least a small area, contained area, and you can use an air filter. But otherwise, it's really a challenge. When you ask patients to wear the N95 mask or the respirators, they cost. And people have to buy it on their own when they have to come. One day, okay, but if they have to wear it every day for X number of days until they're non-infective, it costs money, and that's a huge challenge. So these are some of the challenges we do face in the private sector. Just there is a resource construction even in the private sector, and infrastructure is more difficult because you have everybody everywhere, and it's a challenge. I will end here.
Thank you. Alina, would you like to add to that?
Yes. This IPC relate to private sector is very a big challenge. However, more than 60% of TB patients actually come to the private sector. So this is a very poor condition where IPC is not really a measurement that are being implemented in many of the private sector due to the lack of knowledge of IPC. And what make me even angry is related to the MDR or DRTB. Why? Because many of private sector refuse to give a service or to open the clinic for DRTB, and they say because of they do not have a good IPC, but they still doing treating the TB patient. But actually, the IPC for TB and MDR-TB is just about the same. If you can do regular TB, that you should be able to do DRTB as well. But this is misunderstood by many of the stakeholders. So with the public hospital, they get more support by the government, providing them with the negative pressure, isolation, giving them N95 and also the other kind of respiratory mask. But not for the private. They have to provide those by themselves, and that's mean that they lost some money. And in private sector, they want to gain some money, not losing money. So this is why sometimes the ideal IPC is not really taking place in the private. So education and this white paper and this guideline is very crucial to be delivered, to be disseminated to private and also the public. And there is a very sad condition. Some people overreacted to this IPC, but some people underestimate, especially in the level of a director or even though if you don't have this negative pressure for your isolation room, but at least you have to start to approach with administrative control. But this IPCs, they got messed up. They don't understand. They just think of, negative pressure, N95, but actually they forgot that they can do without invest so much budget by doing this administrative measurement control, saying by differentiate or the patient with coughing and non-coughing one, or make some regulation or something like that. Yeah.
Thank you. Thanks so much, both of you. Paul, I wonder whether you could actually, in your remarks, maybe you could answer the first question in the chat, which is from Grigory Volchenkov, who asks, how can we make airborne IPC a critical priority for the WHO pandemic preparedness agenda? Because I think you touched on elements related to this.
Right, and I think that goes back. I'm just going to back up one. There's an excellent quote in the white paper from the International Labor Organization about a safe and healthy working environment is now a fundamental right for each and every worker. And it goes on. It doesn't say in healthcare facilities. So, I mean, I think, ILO is a much more proactive group than, the WHO's biorisk group or WHO's national TB or global TB program. So I think to have impact, we've tried through the global TB program, and it took us 10 years of pushing to get a few questions added to the annual report. And if we take a look at the annual report for 2024, I know 2023 is quoted in the document, but it just came out, and there are total of four sentences to address TB infection prevention and control in the whole document, plus a figure. So, is that well balanced? Does that really give us enough information for impact? It gives us some information that we've known for years and years and years, and that's that healthcare workers are at greater risk than the general population. Where we don't have data is TB in the community. majority of the TB patients don't go into the healthcare facilities that we're talking about. So we really need to talk about, TB transmission in the communities. How can we, educate and stop the transmission in the communities, in addition to providing environments. But if we provide healthy work environments beyond healthcare facilities, then we're informing the general public of TB and other diseases. And that in turn should help with some of the stigma issues that there are. So I'm going to go back to the issue of thinking beyond just healthcare facilities. And for Grigori's question, the folks, and I don't mean to be negative on WHO, but some of my comments are not positive. But the folks that were involved in the global response for COVID-19, worked, long hours and did some great work, but they used very limited resources to inform their policies. And what we need to do, and I think maybe that's what Grigori is asking about, is we need to be able to infiltrate, the global preparedness or pandemic preparedness response groups, and make sure that they understand that, there are people that have expertise in transmission-based precautions or airborne precautions. We have people who, have, TB, which is a portion of airborne transmission precautions. So again, if we look beyond TB, I think we'll have more impact. Over.
Thank you. Really appreciate those comments. I wonder, because this is the time for the Q&A as well, so if people would like to pop questions in the chat box as well, that would be great. We have another question from Goodman Makanda about how we work on this IPC tool to make sure all people entering facilities are wearing masks, not only in TB rooms or people who have TB, similar to that sort of universal mask approach that we had for COVID-19. I wonder, Erica, perhaps in the context of your work at the City of Cape Town, maybe you have some comments about this?
Hi, Ravandi. So, I mean, I think, obviously within the IPC guidelines that we developed at TBProof and submitted to the National Department of Health, we recommended universal mask wearing. I think generally there's policy already which exists, which stipulates that health workers, and maybe the definition of a health worker is limited. And we expanded that definition within the implementation guidelines to include the groups that were also mentioned in the white paper. So, anybody working in a health facility. But I think currently more focus is normally put on the frontline workers, well, the clinical staff, let me say, who are seeing a patient, and maybe not community health workers or your cleaning staff or anybody who's maybe coming in and out of the facility, caterers or people, doing work in the facility, maintenance, repairs. And obviously it's known that those people are also at risk. So it's important that that definition be expanded. I think probably where there's gaps is, I mean, you can walk into any facility in the Cape Metro and see that very few health workers are actually wearing masks. And while it might be stipulated in a policy that you're supposed to be wearing a mask, I think the fact that there's not people that are maybe necessarily appointed to overseeing IPC, or maybe if there are, they're very few people, so it becomes hard to actually monitor that, I think. And I think it comes down maybe to the facility manager at a facility, if they're really on it, maybe they'd be encouraging their staff to wear masks. But yeah, I think it's not something that also is people are getting performance managed on, for example. So I think, if there were, and I don't know, it sounds bad, but I think if it's kind of incorporated in your job description and it's a mandate, and you know you can get in trouble for not doing it, then it could be something that maybe, and it shouldn't be a punitive thing. It's to protect yourself. But I think, again, within the city, there's probably not enough focus as well from an occupational health standpoint to educate health workers about their risk and to kind of reinforce policy. But it's kind of this whole risk benefit and ethical considerations that come into play. So, I mean, I think the frameworks exist, but the implementation of those frameworks is still very lacking, and who's covered within those frameworks is lacking. And so I think, you know, to improve governance of these matters, maybe it's something that, you know, we need more focus on having champions who are overseeing IPC and occupational health, who are actually really supporting health workers to, you know, wear masks in their jobs, and then also to support the use of masks in facilities for all patients. Yeah. It's complex, though.
Thank you. Yeah, it is complex, and I appreciated the comments from Sunitha and Lena about this of who carries the cost of wearing masks. You know, per Goodman's question about if it's patients, then that is going to be a challenge, particularly over a prolonged period of time. I'm conscious of time, so there is another question on the chat, which maybe panelists might have some thoughts on. It's from M. Prasithio Wodoyo, and it's asking, should there be a quantifiable standard for health facilities with adequate versus inadequate IPC, so that statistics and progress of health facilities with adequate IPC can be reported and sort of actioned upon and follow up? So this kind of performance improvement aspect that we've been kind of thinking a lot more in terms of other TB cascade of care metrics. Any thoughts from anyone on the panel, brief thoughts about that?
Well,
I think Emily, yeah, please go ahead.
I think conducting a IPC risk assessment is crucial, and this includes evaluating current practice, identifying gap in infrastructure and training, and also setting up protocol for IPC monitoring and compliance. And for a facility aiming to strengthen airborne IPC, initial investment in basic resources such as installing a proper ventilation system, setting up patient flow pattern to minimize cross-infection, and ensuring consistent access to personal protection equipment are essential. And training healthcare staff in IPC principle like respiratory hygienists and the correct use of masks lay a foundation for culture of safety that benefit both patient and provider or healthcare worker. With my experience in clinical practice and research, I suggest for evidence-based adaptation in IPC that consider resources constraint without compromising safety. I think that is my answer for that question.
Thank you. There's a comment in the chat from Carrie Tudor highlighting an important point that just because someone is not wearing a mask or respirator doesn't mean they're not complying with the mandate. Based on her experience in South Africa and other parts of the world, nurses and others don't have access to respirators and masks. And this is an important point because you can't use something that you don't have. And I think this is actually one of the reflections that I had on this. And she says that there's often not a budget for IPC. And I think, you know, even in the US context, those budgets exist, but have been cut, which seems shocking in the wake of the COVID pandemic. So I think, and she says, so it comes down to hospital directors deciding where to spend funds, and IPC is usually not prioritized in overall hospital or health facility budgets when resources are tight. So I think that's a key point that I think a lot of the discussion from the panelists brought out. I wonder, just in the last couple of minutes, whether each of the panelists would like to share like 30 seconds of closing remarks. Maybe why don't we go from Paul? Why don't you start?
Sure, and just to end on a very positive note for WHO, if we take a look at the 2019 TB infection control guidelines, and also WHO's the World Health Report 2006, Working Together for Health. The definitions of health workers are, are overarching. So it's not just the nurse or the first provider. It includes the mother who's helping care for her child. It includes using a specific example, the painter, and that's what we need to do when we're talking about reaching beyond healthcare facilities and beyond. Over.
Thank you. Wubshet, would you like to go next?
Sure. So there's something I want to focus on, especially our mindset, the mindset of the healthcare workers. Usually when we, as health worker, we tend to see ourselves as indestructible, immune, something like that. And so it's not the case, right? So we all have seen ourselves, our colleagues, including me, suffering from one of the deadliest diseases, which are airborne, infectious, and everything. So it starts from us. We have to abide by those IPC requirements, rules, and everything. So if we have to wear a mask, we have to wear a mask. So I think the mindset should be the first that should change. That's what I see, and I think.
Thank you. Elena.
Yes. I think IPC policy need to be institutionalized. And we here with the TB community and global health leader should push for policies that guarantee IPC resources, training and oversight, ensuring healthcare settings are safe as possible for both patient and also providers, health provider. And we need collaboration. Nothing happened without collaboration. So through collaboration and share knowledge, we can work towards a safer, more resilient healthcare environment that protect those on the frontliners. Thank you.
Thank you. Erica?
Oopsie, sorry, the mute wasn't undoing. I think just generally to maybe highlight some of the positives. So I do think that maybe there are some shifts in terms of improving IPC in healthcare facilities, and I'm speaking from the context of the Cape Metro. So as I mentioned, we're looking at expansion of multi-month dispensing models for chronic conditions, HIV and TB, so that those are policies which will help to decant our facilities. And I think, again, the positives from COVID, it taught us to think and innovate and maybe think about triaging patients a little bit differently. We are implementing appointment systems in our facilities, which will also help declutter our facilities and reduce congestion. And I think, from the points that were raised earlier around, it's harder to change existing infrastructure versus ensuring that buildings are built in compliance with IPC regulations. We do have good guidelines around facility infrastructure build and ensuring that new builds are in compliance with guidelines put together by the CSIR to ensure that there's proper ventilation in new builds. And there are several new hospitals which are being built across the province in the Western Cape. So just ensuring that those guidelines are followed to ensure improved IPC. So I think there are some areas where hopefully we're going to be seeing some changes, but obviously I do think we need the political will and commitment, investment in training with regards to IPC and having a guideline that's endorsed by the Department of Health and then implementation guidelines that can support you know, taking that guideline into practice. And hopefully that will be coming following the work that we did, even though it's quite delayed. So I do think the political will needs to be there, and obviously then engaging with the community, engaging with community leaders and influential groups within the community in order to ensure that there is education exchange and people are empowered to know their rights as well.
Thank you. Sunitha, realize we're at time, so I realize people may need to leave. We'll try and wrap up very shortly. Sunitha, please go ahead.
Thank you. I would just reiterate what Paul had told earlier. IPC does not mean restricting to the hospital. We are talking about containing tuberculosis. So if you have to contain tuberculosis, you're talking about IPC, not just in the hospital, but outside as well. People meet in at work most of the time, at home most of the time. Better ventilation at workplaces, be it factories or offices. We need more research in terms of how to improve the IPC in these places. If you can convince opening windows, creating more ventilation, that would make a huge difference. Otherwise, the cost of trying to create an proper airborne precautions in a workplace is very, very difficult. So this is areas that we have to focus on if we have to get a control on ending TB.
Thank you so much. Really appreciate the panel's time and thoughts on this important topic. I think lots of reflections for me, particularly I think about how we sort of leverage the policy aspects. So I look forward to further conversations about how we can sort of advance the IPC agenda, not limited to airborne IPC, as well as not limited to health facilities. And funding is obviously a big part of this, as well as sort of ways to actually improve on the tools that we have to use them and also measure and evaluate them. I'll pass it back to Yannicka.
Well, thank you so much to you, Randy, for moderating, all our excellent panelists and everyone that's dialed in to join, especially as we've overrun ever so slightly. I'll just close by flagging that for those who haven't already read the new WHO Global TB report that came out yesterday, you'll see that WHO has again confirmed that healthcare workers have a higher rate of TB than the general population, really underlying that risk that they face as part of doing their work. There's also a new section on asymptomatic TB disease, which I think is something that we're becoming increasingly aware of and that really underlines the importance of integrated action on IPC across healthcare facilities, but as we've just heard, also other kind of high-risk transmission settings. With that in mind, please do download the white paper. The link is still in the chat, or you can just visit the Ending Workplace TB website, share it with colleagues, partners, and friends. And if you have any ideas or feedback, we'd always love to hear from you, but we'll wrap up there and wish you all a good rest of the day. Thanks, everyone.
Thank you.
Thank you, everyone.
Thank you.
Thank you.
Thank you.